see that this is not extra work. This is a reinforcement of the work that we're already doing in practices. And a lot of the burden of this work will be done by the Federation for you. Very similar to the AF trip, so a lot of these searches and stuff will be done, a lot of for you, and highlighting the patients that need to be involved in this program and what work needs to be done and the recommendations. And then a lot of the work will be done by Medicines Academy and CityFed if you feel that you're happy to delegate that work to them, and then the program will provide like a quality audit profile for your practice. So why are we concentrating on diabetes? Well, I don't need to tell you how important it is in City. We've stressed it so many times. Why is it different from the other quality improvement projects that the CCG roll out, the NHS England roll out? Well, a lot of this work will be done by the Federation for you. It'll highlight those patients that need a targeted approach with their care, and a lot of these patients are the main burden and challenge in our practices in terms of repeat admissions to hospital, complications from diabetes, often non-compliance with medication, poor engagement with structured education, and stuff like that. So in terms of this quick presentation that I'm going to give you on this program, we're going to talk about partnerships, how we work in this project, the QIP itself, its context and how the process will work, and then a little bit of oversight of the Federation guideline for the targeting of these patients, how we ought to manage them, a little bit of the evidence base behind what we're trying to do, and then at the end there'll be some sign-up sheets for member practices if they feel that this quality improvement project would benefit their practice. They can sign up, and we will then, as we did with the AF, get in contact with you, and Roman and myself will work through the project a practice at a time and make sure that you're engaged and that you're happy with everything that's going on in the project. So I'm going to just do the introduction, and then I'll let Roman go through the actual context and process of this quick. So why? Diabetes, highest prevalence in the country. We know that. In the country, we have got the highest prevalence. That is a star award that we win every year. The prevalence rate in Bradford is well above the UK national average. I think we're running at 10.4% now, and probably there's quite a few diabetics that are floating around that we haven't found yet, and so I suspect that's going to get even more. And why? Mainly because we've got a South Asian demographic, and that results in 3-4 times higher prevalence of diabetes in our population, despite our young population. Most of the diabetes specialists here and the GPs that work in the diabetes clinic know that treatment to target is so difficult. It's one of the markers in QOF and the DQIP that we find so hard to meet. Often blood pressure and cholesterol we can get, but HbA1c is so difficult, and there's multiple factors that affect that, and it's often nothing to do with the amount of work and effort that we put in for those patients. It's notoriously difficult to handle, and that poor control results in a lot of the quality and complications of diabetes and the quality of life of our patients, and the increase in complications. And that poor control in those patients often leads to the big pressure on our service in terms of repeat attendance at your practice, in terms of admissions to hospital, in terms of all the other social consequences of poorly controlled diabetic patients. And obviously there's a big money factor in the sense that they cost the NHS a phenomenal amount of money and affect their budgets. Why are we doing this project? We hope to improve the outcomes through this by giving practices a bit of support through this quality improvement program. It's all evidence-based, so this is not hearsay, this is all evidence-based treatment and, I won't call it pathways, but protocols for managing these patients and options really to have the biggest impact on reducing their complications and reducing their mortality. And it hopefully will support the excellent work that you guys are doing in your practice by providing you with an additional care and support through the Federation and Medicines Academy. Why are we doing quality improvement? Well, there's a couple of things that will come out of this. CQC is incredible pressure on practices. I think a clinical audit like this will definitely benefit your practice. It's something that you can show to the CQC when they come, and I think they'll be pretty impressed. It's all evidence-based, and it's a pretty detailed quality improvement program that we're doing that will be specifically targeting those patients in your practice that are suffering the most from diabetes and most likely to benefit. And it shows quality of care, improvement in quality of care and engagement with patients and their carers. So it ticks that box, and it's important. It really does identify and tackle the health inequalities in our population. There's a massive difference in the prevalence of diabetes between ourselves and our neighbouring CCG, and also the life expectancy of our patients compared to our neighbours, which is, I think it's 12 years between the centre of Bradford and a place like Ilkley. 12 years difference in life expectancy, and most of it is cardiovascular disease and diabetes. It'll help with your CCG quality assurance visits. So if you've done this programme, Roman will provide you with a full audit report, which you'll hopefully action or allowed him to action, which you can put in front of the CCG when they do your quality assurance report. So when you get triggered for GPOS for diabetes care, it's one of the triggers, HbA1c, triple target, you can say, look, we've done this programme, we really are trying our best, we're engaging with our patients, and we are referring them to structured education, we're managing their diabetes as best we can, we're checking compliance, and all the other issues that we're going to go through in this process. And finally, it will help in your appraisal and revalidation. As the lead GPs in that practice, you're managing a very important chronic disease factor and the complications of using evidence-based. So that will definitely be something that you can put in your CPD and your revalidation and appraisal package. Partnerships. This federation is one of the first in the country to do a collaborative joint working project, which we did with the AF Quip. It was the first in the country. It was so successful, and I hope that you found it successful and easy to engage with, and felt that it did give you some important information about your AF register and your patients with AF. And we found quite a few more AF patients through our screening, through the My Diagnostic. And it just means that we can work more collaboratively with pharma. In this case, it's NAP. We're going to work very collaboratively with them, and we're trying to optimize the medicines management in diabetes and also the clinical care as well. And we're trying to do it at scale. So rather than a small practice or a reasonable sized practice, we're doing it across the whole of our population. And our federation has grown now to the point where we are almost in fact we are bigger than the CCG, city CCG population.
I think we are, yes.
We are. So we are actually doing it at a bigger scale than city CCG.
Much less budget though.
We're doing it on a smaller budget. And we are actually putting some investment in primary care, and it's an investment from the Federation, which is match funding the investment from pharma, in this case NAP. So it's truly collaborative, and hopefully it will drive up the quality of care. And it is a bit of a trailblazer, really. Not many federations are doing it. I think a lot more will once they hear about our success and what we're trying to achieve here. And it will hopefully benefit the patients, the NHS, and it will have an effect on pharma as well, because they found a better way of working with federations or practices directly rather than through third-party people or trying to knock on the door of CCGs or NHS England. So there's a lot of scope for future working. The reason we picked this project is that it's a proven project in diabetes care and improvement. It has been done by Medicines Academy. The same project has been done through their team in 12 practices in Calderdale and Kirklees. Now I know it's a different population from ours, but there are pockets of that population that do reflect, are very similar to our population. And that program produced a positive outcome in terms of the improvement in these targeted patients in their HbA1c, their blood pressure, their cholesterol, and their compliance with medication. And most of these factors actually impact on the quality of care that these patients receive, and also their outcomes and how they life expectancy and complications from diabetes are affected. So I'm going to hand you on to Raman now, who's going to go through this project and hopefully spell out to you what the evidence behind it is, how it will work, and how they'll engage with practices that would like to sign up for this. And at the end of the presentation, we're just going to give you a quick update as to how to sign up to the project if it's something that you feel would be a benefit to your practice. So I'll pass you on to Raman now.
Okay, so the project objectives are here. So it's to identify all the patients who are on your diabetic register who are missing the first 006. So they've got a HbA1c of 59 and above, and those that are type 2 and not on insulin. So that's the patient profile that we're targeting within this project. The interventions are designed to be made with obviously nice guidance, which I'm sure you're all familiar with, but also the ADA and EASD guidelines that came out last year, which has more of a focus on patient phenotypes and individualized therapies. We'll hopefully look at triple target control, so we'll identify patients that are missing blood pressure targets as well, and try and provide some pointers as to optimize the therapy with them as well. And any patients that would benefit from structured education or further support. Okay, so this was a data pulled in January, so that's the federation population, and that's the diabetic register across the member practices. So quite significant, and as Dr. Gilcar said, it's probably bigger than the CCG. As part of the DQIP that's going on at the moment, which is focusing on the triple target, in the member practices, the achievement is 32%, so still quite a lot of work to do, and I know there's a lot of effort being made by practices on that. The number of patients that we're going to look at as part of this project equates to around 25% of the diabetic register, so again quite significant numbers that will get audited in your practices as part of this. And around 50% of these have established cardiovascular disease, heart failure, and hypertension. So quite significant number with some kind of pre-existing cardiovascular disease. Okay, so you're all familiar with the NICE guidance, I'm sure. And the central theme of the NICE guidance was the attainment of glycemic targets with a focus on the lowest acquisition cost. And there was, after metformin, there was little steer on which patients would benefit from which agent, and it was just left to clinician discretion really as to when you saw the patient and what you'd like to do with them. The ADA and the EASD guidance went a bit further than NICE guidance, so and they provided a comprehensive patient-centered guidance. So after metformin and lifestyle advice, which should be the intervention in all our diabetic patients, the next steps in the management are driven by patient phenotypes. So those with established atherosclerotic CVD, CKD, and heart failure, so there's a specific pathway for those patients to follow and recommendations on what agents to use for those patients. And there's also additional considerations if hypoglycemia is your main concern with some patients, what should we use and what should we not use, and if weight gain is an issue, again, what to use and what not to use. But it also considers safety, tolerability, and cost as well. Okay, so that's the pathway that's been sort of in development with Hussein and Dr. Gilcar, and I'm not sure if it's been finalised, but I know it's in discussion at the moment. We've got a tables as well. It is modelled on the ADA and EASD advice, so it's essentially following that. So the process is you're going to get some searches put into your practices in System 1. They'll be run and it'll find all your patients who are eligible for inclusion within this project. And then what they'll all essentially get audited. So we'll look at what kind of what medications are on for diabetes, whether it's suitable for prescribing, whether there's scope to titrate medication to try and achieve HbA1c control. And you'll get recommendations as part of the audit for your practice on how to optimize the therapy. And then from the action part of it is, once you've got the actions, it's up to you whether you want to action them yourself or pass it back and we can action them as well. You'll also get recommendations on patients that need blood pressure doing or a up-to-date HbA1c group as well. So we've already started this at Clarendon practice, and the number of patients that were initially audited are 231, so quite a few to go through, and of those there's roughly half with established cardiovascular disease, and that's got considerations when you look at the ADA and EASD guidance as to how we can treat them and recommendations for therapy. Okay, so we're looking to use the CCG diabetes formulary, which has first line and second line agents recommended. There's obviously the local guideline as well and adoption of that. Patients, there's been quite a few patients that are needing up-to-date HbA1cs and blood pressure, so you can't proceed with them or make a recommendation until those are done. So that's one set of actions. And then once those are done, they will get tasked to me and I will see them in a clinic or I'll speak to them on the phone and we'll make a decision optimizing the therapy. So yeah, patients will be informed, so they'll get some contact and obviously reinforce lifestyle advice that each patient constantly that we do. And if there's any other key care processes or pathology do, these will get tasked in practice to action. Okay, so I've had a few discussions with NAP, and essentially there's the Canvas trial, which Professor Donald will talk about, and the evidence was quite compelling in the use of SGLT2s in patients with cardiovascular disease. So they've done a piece of work around overlaying the federation population that would have been suitable for the trial, and if we made an intervention in line with what the Canvas trial did, alongside standard care that patients already receive, 50% of the patients within the federation would be suitable for the trial, and what Canvas showed was a 14% reduction in the combined risk of CV death, non-fatal MI and non-fatal stroke. So 50% of the patients within the federation are actually replicated within the trial. So if we can hopefully reduce combined risk of death, CV death, non-fatal MIs and non-fatal strokes, that's something useful market. We're quite high prescribers within the practices of sitagliptin, and the TCOS trial did not show any meaningful CV benefits. But yeah, we've got a lot we them, and we don't de-prescribe them either. So again, something that we'll be looking at as part of the audit. Okay, so as mentioned, approximately 25% of the diabetic register will be reviewed as part of this audit. And if we can optimize therapy and extrapolate the Canvas trial data into real-world data, at year one, if we can make similar interventions as to what they did with the trial data, the data that's been provided shows that there'll be a minus 17 in major adverse cardiovascular events in that population, and also a reduction of 5 in the number of CV deaths at year one. So it's quite significant. And if there's a legacy effect left from doing these projects and they continue the same being at year 5, there can be up to 153 reduction in major adverse cardiovascular events and a reduction in 42 deaths related to cardiovascular disease. So again, quite significant. So NAPA here in the room, and they can provide support to practices by providing supporting information. So some of the
We'll have a question and answer session after Professor Dolman as well.
I'm sure Professor Dolman don't think that's Professor. So NAP can provide support with any patient materials that you might need, and so the data I've just showed is their cost offset model, and I'm sure if you wanted to see the population for your practice, that would be suitable. Provide that for you as well.
So this is just the last bit really. It's just about how do practices engage in this process if they want to sign up to it. But there's a signing in sheet that the managers from CityFed are going to hand out. It just needs to be signed by the lead GP or the lead practice manager from the practice. Once we've got that, we're going to cascade that information to you, and we'd hope that you would then cascade this to your practice teams. And what we're trying to do is, as I said, implement evidence-based, especially with regards to those at high risk of cardiovascular disease. And we're going to support the program and the practices. Any help that you need from ourselves, me and Wahid, from Raman or from NAP, we can help and support you in any ways, potentially helping to implement those recommendations in your practice. And finally, the most important thing is, this is not a switch program. So don't want you to go away, oh, this is just a switch program. It's not. It's not about switching patients, it's about improving the quality of care. And the reason that pharma are engaging with us and investing in this is that we're match funding the investment with our time and effort. And two, it's a better way for them to work with primary care rather than third parties coming in and doing futile audits that look good but actually don't achieve anything. This is investment in primary care. So the whole point of this is investment in primary care, so engagement payment to the practice to engage in the process if they're happy with it, payment at the end once the actions and recommendations that you feel are appropriate are actioned in your practice for your patients. And then the last thing I think we just need to highlight for those practices that are level 2 level 2 or level 3 clinics, we are not looking at those patients. They will be level 1 patients, because obviously we don't want to step on the feet of experienced clinicians who are already dealing with complex patients. There's probably a chunk of those people that we could help with. If you want to pass those patients onto Raman for him to have a cert, otherwise we're not touching those patients, because you guys have that experience, you know what kind of issues they have in the complications. This is the level 1, which is quite a large chunk of anybody's diabetic register. So Nicole and Elaine are going to hand those sheets out, and if the lead GP or the lead practice manager, if the GP is not here, could sign that if they're interested in joining the program for the coming 6 months it'll take 6 months to 9 months to complete, and then we will then contact those practices to get you involved in the process.
When you started?
Clarendon's been done, and it was quite a smooth process.
Quite a smooth process. I mean, there wasn't hassle for the practice at all. Raman's team, they've already done the atrial fibrillation quality improvement program, so they're well versed in how our systems work. And they've made some recommendations already, so we'll be active on that. I mean, one of the things I like to say is that we've got POS coming up, and probably coming up to the year end. And I probably have to say from a practice point of view, and I think all of you probably have a similar experience, diabetes is probably one of our most difficult ones to get people to target all the time. Every year I have a conversation with my team, and I think if we can help and support our team, our practice team, with regards to the quality improvement, help them in terms of optimization, that's what we need to help.
So I know it's coming towards year end, and practices are busy around March with the end of year course, the reporting templates and God knows what. So we're going to try and aim for April. And then the order that we don't have an order. So in the previous program we started with the board members, because the GPs that are on the board kind of like to get their practice. But this time we don't have an order. So I'm going to send out an email everybody, with all the practices. And those practices that are eager to get started straight away in April, or would like it a little bit later in the summer, or maybe would like it in the autumn, you can just kind of put your preference, and then we'll go around the practices so that it's convenient for the way that you want to run in your practice at one time of the year. So once you've signed those practices that are interested in the sign sheet, could you hand them back into Nicole or Elaine, and then we can collate all those practices that are interested and contact you in the coming weeks?
Okay, so I'm just going to invite Professor Richard Donnelly, who's Professor of Medicine at the University of Nottingham, consultant physician at Derby Teaching Hospital and NHS Foundation Trust, to talk to us about vascular complications of diabetes and cardiovascular therapeutics.
Right. Okay, good evening. I'm conscious that you've probably had a long day, so my challenge is to maybe see what I can give you in the way of some simple take-home updates that are relevant to your practice. I guess a few years ago it used to be that there were GPs with a sort of special interest in diabetes. But now, unfortunately, particularly in this part of the world, even if you hate diabetes, you can't avoid it, can you? So more and more GPs are all engaged with diabetes because it is so much of a comorbidity in all of your patients that nobody in the practice, I guess, can afford not to be up to date with diabetes. So I'm going to talk a little bit about diabetes in general and give you some topics that I think are fairly hot, and then I'm going to talk a little bit about some of these cardiovascular outcome trials and why guidance, nice guidance, American, European guidance has been revised in the course of the last 6 to 12 months to acknowledge that the results from these cardiovascular outcome trials are genuinely sort of game-changing in terms of benefiting mortality for patients. So diabetes is a big problem. It's a big problem globally, and it's a big problem locally. In the UK, we're probably up at about 5 or 6% on average, but as you heard earlier on, in this part of the world, it may be as high as 10% that the prevalence of diabetes. And that diabetes, you still must remember, is classified simply as type 1 and type 2. But something's changed in the last years since you and I were at medical school. So when we were at medical school, we learned that you could train the tea lady to spot the difference between type 1 and type 2. Type 1 was all stick thin, kids. They all became immediately sick with DKA, and it was dead easy to spot, and they needed insulin. And then over here was middle-aged, older, fat people with insidious onset hyperglycemia, and they have type 2 diabetes. And the two populations were a mile apart. Well, that is no longer the case. And actually what has happened over the last 20 years is those two populations are now much more superimposed. So for example, in the last 6 months, I've probably diagnosed about 5 or 6 people with type 1 diabetes over the age of 60. And they were all referred in. This patient has got lousy diabetic control despite metformin, sitagliptin, and something else, sulfonylurea. They've had a diagnosis of diabetes for 2 years, and their A1C's never been below 10%. Do you think they need a GLP-1 agonist? And actually the patient's got type 1 diabetes. So as you get older, type 1 diabetes is less abrupt. You become less sick. You don't develop ketoacidosis. But you do smoulder in primary care. And there's a tendency for everyone in primary care to think that everything that comes through the door that's got diabetes, that doesn't look acutely sick, must have type 2. So one of the real messages from tonight is that it's absolutely okay. And you nurses, when you see patients coming in, just pause for a second and ask yourself, does this patient have type 2? We've labelled them type 2 every month for the last year. But do they have type 2? And are there any features here that might make you think that they might have actually type 1 diabetes? And there's some good data from Kamlesh Kunti, who's the Professor of Primary Care in Leicester, showing that probably up to about 10% of patients in primary care are misclassified as having type 1 or type 2 diabetes. So it's much more difficult to distinguish the two populations. And as you get older, you get a slower form of onset of type 1 diabetes, often known as LADA, latent autoimmune diabetes in adults. They don't become ketoacidotic, they don't become acutely sick, but they don't respond to metformin either. And they become very symptomatic. And their body mass index isn't quite as big as you might imagine. So take a family history. You can measure their islet autoantibodies on a venous blood sample, and that can help. And if you're not sure, send them to secondary care. And I can tell you that in secondary care, we scratch our head and we discuss it amongst ourselves, and we're not sure whether the patient has type 1 or type 2 diabetes. So it's definitely okay to put your hand up and write a short letter to this secondary care and say, have a look at this patient, do you think they've got type 1 or type 2 diabetes? Now 10 years ago you'd have all said, God, I wouldn't dare write a letter like that. That would make me look completely stupid. But actually that's definitely not the case. That's a very astute question to ask. And so I would encourage you to critically ask yourself every time you see a patient, just be sure, just because your colleagues have all labelled it as type 2, especially if they're not responding to metformin, ask yourself whether actually the diagnosis is wrong and they do need insulin. So why is diabetes such a big problem? It's a big problem because it reduces life expectancy. On average, by 10 to 15 years, less life expectancy as a result of diabetes. And if we're diagnosing type 2 diabetes in younger and younger age groups, then it means that that reduction in life expectancy is even greater. And it's those younger patients where it might be very difficult to distinguish type 1 and type 2. Anybody heard of MODY? Maturity onset diabetes of the young? There is a MODY risk calculator. If you go on to diabetesgenes.org, there's a risk calculator that's owned by the University of Exeter. So if you see a young patient with diabetes, say below the age of 30, and you're not quite sure whether this is a familial genetic form, you just go onto that website and you enter a few details, and it'll tell you what the chances are that this patient may have a form of MODY, which is the other type of diabetes which can complicate the diagnosis. But these are all the premature complications that result from a diagnosis of diabetes. We know about accelerated cardiovascular disease. We know about retinopathy, neuropathy, and renal disease. Remember, there's a higher risk of certain forms of cancer in people with diabetes. They have more sleep apnea. So everybody who's got sleep apnea should have been screened for diabetes. And when I talk to the gastroenterologists, they tell me that their liver clinic is now a tsunami of patients with fatty liver disease. Deranged liver function tests. You do an echo, an ultrasound of their abdomen. The sonographer says highly echogenic texture of the liver. That's all fatty infiltration, causing insulin resistance in the liver, which in turn drives hyperglycemia. There is a relationship between HbA1c and cardiovascular disease. So all this premature cardiovascular disease is related to HbA1c. And that graph is a straight line. The higher your HbA1c, the higher your risk of cardiovascular disease. And that straight line extends down even into the pre-diabetic range. Remember, we can use HbA1c now to screen for diabetes. It used to be that we only used HbA1c for surveillance, but we can now use it for screening and diagnosis. You don't need a fasting sample. If it's above 48 millimoles per mole, or 6.5% in the old currency, then that gives you a diagnosis. But that straight line extends down even into those patients who've got impaired glucose tolerance, who are not yet overtly diabetic. Diabetic kidney disease is one of those complications that's on the rise. There are more and more patients with proteinuria who then develop a glomerulosclerosis of their glomeruli, and then in the later stages of diabetic renal disease, they show a reduction in EGFR and worsening renal function. And the moment you have proteinuria and impaired renal function, your cardiovascular risk more than doubles. So you're much more likely to drop dead from heart disease before you require dialysis. So renal disease is a marker of even higher risk of cardiac events. And the cardiac events are likely to kill you before you require renal replacement therapy. And the other big complication that's emerging in all of this is the incidence of heart failure. Heart failure is more common in patients with diabetes, and the prognosis is worse among your heart failure patients who have diabetes. So again, all your heart failure patients ought to be screened for diabetes because the two often go together. But because the cardiologists are managing to keep people alive, but they've all got damaged ventricles, we're now seeing a big increase in the risk of heart failure. Some of that heart failure is due to coronary artery disease, but a lot of it in diabetic patients is not due to coronary artery disease. It's due to a so-called diabetic cardiomyopathy. And they often have a preserved ejection fraction on echo. But they'll have an elevated BNP, they get breathless on exertion, they get some peripheral edema, they have all the clinical signs and symptoms of heart failure, but they have a preserved ejection fraction and their prognosis is worse than a patient without diabetes.
Should those patients be put on the heart failure register?
Sorry?
Should those patients be put on the heart failure register then? Because the heart failure register for QOF is about left ventricular systolic dysfunction.
It is.
But you're saying left ventricular.
That's right. So heart failure is divided into two sort of groups. We make a clinical diagnosis, symptoms, signs, orthopnea, a bit of peripheral edema. We make a clinical diagnosis. We can then use echocardiography to look at left ventricular systolic function. Classically, all the trials of drugs like ACE inhibitors, diuretics, beta blockers, those trials were all undertaken in patients with reduced ejection fraction. And so we have a lot of evidence that those drugs in that population work. All those patients with preserved ejection fraction never got into the trials. So we don't have the same level of evidence for intervention. So the guidelines and the QOF will prioritise systolic dysfunction because that's where the evidence base is for you to give an intervention. But the preserved ejection fraction is a big population. And indeed, a lot of, there's an excess of diabetes in that population. But they've still got heart failure. They respond symptomatically with diuretics, and they probably respond symptomatically to an ACE inhibitor. But we don't have the evidence that those drugs will make them live longer. The evidence that they get that they live longer is only with reduced ejection fraction. But for practical purposes, you would manage them the same. But there's less priority in the system because there's less evidence to support it. So, simple reminder, there are 3 abnormalities that drive hyperglycemia in type 2 diabetes. Yes, there is a peripheral insulin resistance. Muscle and fat tissues become less responsive to insulin. Yes, there is a reduction in pancreatic insulin production. And that's particularly true in South Asian patients who tend to develop type 2 diabetes at lower BMI. There is often a genetic component, and that genetic component is often because they don't produce as much insulin. So when they don't produce as much insulin, they develop type 2 diabetes at lower levels of insulin resistance. Does that make sense? So as I put on weight and get more insulin resistant and more sedentary, the first thing that happens is that my pancreas overproduces insulin. So if you see all these patients who are obese but not diabetic, they're insulin resistant, they're hyperinsulinemic, and therefore normoglycemic. But if you haven't got the pancreatic reserve, if you haven't got the beta cell capacity to increase insulin production, then a little bit of insulin resistance is going to tip you into hyperglycemia. And that's the scenario in South Asians. They have genetically less pancreatic reserve. They generate less of a pancreatic insulin response. So they develop type 2 diabetes even with only a little bit of weight gain and a little bit of insulin resistance. So often you might well need to use a sulfonylurea in those patients. They present to you with fairly recent onset of symptoms. They're thirsty, they may have lost a bit of weight, they're younger, they've got relatively lower BMI, it might be in the high 20s. They might well respond well to a sulfonylurea rather than metformin as first-line therapy. So metformin is not for 100% of patients first line. And the people that we might use a bit of gliclazide in are the patients who might well be South Asian, a bit younger, who've got the flavour of a pancreatic insulin production problem rather than a massive insulin resistance problem. Yeah? And lastly, there is insulin resistance in the liver, which means that you have inappropriate hepatic glucose production. So the liver is breaking down glycogen, secreting glucose into the circulation, even in the fed state. And it's the liver is where metformin works. So when you use metformin, you're targeting the liver and you're switching off hepatic glucose production. So let's talk about the sort of cardiovascular outcome story. Many of you will remember 10 years ago we had the glitazones, and these drugs were fantastic because they were going to be insulin sensitizers. They had no effect on pancreatic insulin production, but they improved hepatic insulin sensitivity. And in those days, in order to get a drug licensed in diabetes, all you really needed to do was take a couple of hundred patients and randomise them to get glitazone or placebo and measure whether it lowers glucose levels. And if it lowered glucose levels and lowered HbA1c, we just assumed that it must be good for you. And so we got all the glitazones licensed, and we were all using them very merrily because they lowered glucose levels. And then all of a sudden, a cardiologist in the USA did a bit of a meta-analysis and showed that in fact the incidence of myocardial infarction was higher in patients treated with rosiglitazone compared with placebo. So all of a sudden, we lost confidence in HbA1c. Here was an example where HbA1c went down, but mortality went up. So the regulators immediately said, whoa, 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 whoa. We're not going to license anything else for type 2 diabetes based on HbA1c lowering. Lowering HbA1c doesn't tell us anything. Is it actually going to prevent heart disease and deaths from all these complications? We don't know. Whereas with pioglitazone, in fact, there was no such effect. In fact, pioglitazone probably had a favourable effect on the incidence of myocardial infarction, but it did cause an excess of heart failure. So the regulators issued guidance demanding that every new diabetes drug, including insulin, would now have to subject themselves to a proper outcome trial where you actually start counting bodies rather than HbA1c. So you take 10,000 patients with type 2 diabetes, all on usual care. They're already on glucose-lowering therapy, they're on a statin, they're on an ACE inhibitor. They're all under usual care, and you randomise them to add on new drug, add on placebo, you keep everybody double-blind, and you count the bodies after 5 years. And that was the design that was used for all of the cardiovascular outcome trials. So all of the drugs that we've now been using, the DPP-4 inhibitors, these SGLT2 inhibitors, insulins, glargine, have all had to initiate this type of trial. 10,000 patients, follow them for 5 or 6 years, measure the outcomes, heart attack, stroke, heart failure, death, cancer, all sorts of outcomes. And the purpose of those trials was firstly to demonstrate lack of harm. as opposed to demonstrating a positive benefit. So the trials were all designed to reassure the regulators that there was no rosiglitazone effect, that HbA1c was going down, but complications were actually going up. So all of those cardiovascular outcome trials, some of them are all listed here, and they've all been reported over the last few years. What did they show? Well, we'll talk about the SGLT2 story in a moment, because it has been truly different from everything else. These DPP-4 inhibitors, sitagliptin, linagliptin, vildagliptin, they all showed spectacular neutrality. There was no evidence of harm, but nor was there any evidence of benefit. In other words, you took 10,000 patients with type 2 diabetes in your practice and mine. They were already on existing therapies. You add in sitagliptin, you add in placebo, you carry on with usual care, and you count the bodies at the end of 5 years. And with the DPP-4 inhibitors, there was absolutely no difference in mortality. But there was a signal for slightly increased heart failure with at least 2 of the DPP-4 inhibitor drugs. So those drugs now all carry a caution in their label around heart failure. But they didn't show any benefit. With the GLP-1 agonists, it was a mixed story. These drugs, of course, are injectables. They're double the price. They have an incidence of nausea, which can often mean patients don't tolerate them. And we saw a mixed result. With liraglutide, we saw definite benefits on a combined endpoint of what they call major adverse cardiovascular events. But with lixisenatide, which is often the cheapest and the recommended GLP-1 agonist by many CCGs, there was no benefit on those longer-term outcomes. So there were differences within the class of the GLP-1 drugs for reasons that we don't quite understand. And with insulin, there was absolutely no benefit and no harm. So just to put that to bed, there's no great evidence that putting people onto insulin earlier is going to improve their longer term outcomes. So glargine is not the solution. It may improve symptoms when you've exhausted everything else, but it isn't going to prevent complications. This was the data with saxagliptin, and there was a worrying increase in the incidence of hospitalisation for heart failure. Everything else was neutral between placebo and saxa, and exactly the same finding emerged from the allogliptin trial. So the regulators have applied a warning on all of the DPP-4 inhibitors. So let's talk about these SGLT inhibitors. Remember your days in biochemistry? There are 2 families of what we call transmembrane transporter proteins. These proteins sit in the plasma membrane and they help move glucose in and out of a cell. And on the left, there's the GLUT family of transporter proteins. And on the right, there's this family of sodium glucose co-transporter proteins, where the protein takes one sodium, one glucose, and moves the 2 molecules across the plasma membrane. And there are 6 types of SGLT protein in the body. SGLT1 all the way through to SGLT6. We're interested in SGLT2. And it's convenient that SGLT2 only seems to be expressed within the kidney. So the drugs that we're talking about, which selectively block SGLT2, are only targeting the kidney. There is a little bit of SGLT1 in the kidney, and there's a little bit of SGLT1 in the bowel, involved in glucose absorption from the gut. So in you and I, we filter glucose at the glomerulus, and we filter a large amount of glucose into that proximal tubule, and then we reabsorb all of that glucose back into the circulation. And that tubular reabsorption is mediated predominantly by SGLT2, with a little bit of SGLT1. So in you and I, we don't have any glucose in the urine. But clearly, if we use a drug, the SGLT2 inhibitor, to block that pathway, then we start to push glucose downstream and we get glucose in the urine. So these drugs were developed. Who can tell me when the first SGLT inhibitor was licensed in the UK?
2012.
Sorry?
2012.
2010. Now I know that we're a bit conservative and we're a bit slow on the uptake in the UK, but for God's sake, it's 9 years since these randomised trials with these drugs first appeared in the Lancet. And so they're not that new, is one of the important points to mention. And so some of our conservatism in the UK is no longer sustainable when the drugs have been actually in our formulary for about 9 years. And there is now a massive amount of information globally about the efficacy, safety, and the utility of these drugs. So don't think of them as something that's just come out. Think of them actually as something that's been around for quite a long time, but we've been relatively slow to adopt their use. So, a few things to mention on that slide. Firstly, there is no mention of insulin on that slide. So these drugs work completely independently of the beta cell. Whereas, as you know, DPP-4 inhibitors, GLP-1 agonists, sulfonylureas work on the pancreas. And in order to get the glucose lowering effect, you have to have pancreatic beta cells that are functioning. And over time, you get a deterioration in beta cell function in type 2 diabetes. So the durability of the glucose lowering effect is limited in patients treated with a DPP-4 inhibitor or a GLP-1 agonist. So these drugs work even if you haven't got a pancreas. And indeed, before very long, we'll be using them in patients with type 1 diabetes as an adjunct to insulin. But for here and now, we'll stick to type 2. So the mechanism of action is insulin independent. The second point to note is that for these drugs to work, you have to be filtering glucose at the glomerulus. In other words, you have to have a reasonable EGFR. Now, at the moment, you shouldn't initiate these drugs unless the EGFR is above 60. And the reason for that is because the glucose lowering effect will not be as good if the EGFR is reduced. But I will talk a little bit about the fact that these drugs are now appearing to have benefits on the kidney that may have nothing to do with glucose lowering. And therefore, in the future, we will probably be using these drugs in patients who have reduced EGFR. But in terms of glucose lowering potency, you're going to get maximum bang for your buck if the EGFR is over 60 before you initiate the drug. So for here and now, you want to concentrate on using these agents when EGFR is above 60. These drugs are diuretic. They promote glucose elimination, they promote diuresis, they promote calorie loss, and they lower blood pressure. So the randomized trials have shown that they lower HbA1c extremely well, they lower body weight, and they lower blood pressure, all on top of whatever you're doing as part of usual care. And if you're not sure whether the patient is taking the medication, you can dip the urine. And if the urine isn't stuffed with glucose, then you can eyeball the patient about compliance. This just shows a zoomed in picture of how that SGLT2 protein sits in the epithelial membrane. It brings sodium and glucose into that cell, and then it goes out of the cell and back into the circulation. A couple of things about these drugs that you'll have heard about. You may have heard a little bit about ketoacidosis. So these drugs increase fat oxidation. We're not quite sure how they do that, but they do increase fat oxidation. And so if you were to measure ketone levels in these patients who are on an SGLT inhibitor, ketone levels do go up, almost as if they're starved. But rarely, and it is rare, these patients can develop ketoacidosis. So an element of ketonemia is quite common, although we don't normally measure them. But ketoacidosis is rare. And therefore, in practice, the advice is the same as you would give to your patients on metformin. If you become sick, if you're vomiting, if you become dehydrated for any reason, stop taking your metformin because of the risk of lactic acidosis, and stop taking your SGLT2 inhibitor because of an unlikely risk of ketoacidosis. But it is rare. They have an insulin-sparing effect, so some of the best experience of using these drugs is actually to add on to insulin. You'll have a group of patients with type 2 diabetes, they're on 100 units of glargine a day, their BMI is getting bigger, their HbA1c is still high, and they're very insulin resistant. And you can add in the SGLT2 inhibitor, and you can drop the dose of basal insulin by about 25%. And it helps facilitate a bit of weight loss, and they get a very good glucose lowering effect. So if you haven't used SGLT2 inhibitors much, that's a great population to start with, because they're often the sort of heart sink patient who's now exhausted all oral therapies. They're on insulin, but the insulin doses are creeping up, their BMI is creeping up, and their A1C is still off target. The commonest side effect, as you know, is not urinary tract infection, it's genital mycotic infection. There is only a small increased risk of UTI, but there is a significant risk of balanitis and vaginal candidiasis. The randomised trials have shown that these drugs work very well. They have very substantial HbA1c lowering effect. There have been meta-analyses that have compared the different doses of canagliflozin with the different doses of empagliflozin or dapagliflozin, and I think it's true to say, as is shown here, that 300 milligrams of canagliflozin is higher up the dose response curve than anything else. So if you want the most effective regimen, you will get it from canagliflozin 300. But the standard practice would be to initiate 100 milligrams once a day, and if the patient's tolerating it, increase the dose, and you will get an increase in glucosuric effect and an increase in HbA1c lowering, which is superior to what you would get with DAPA or with EMPA. So the whole story about cardiovascular outcomes, going back to the 10,000 patients randomised to add-on versus placebo, the first of the cardiovascular outcome trials to present was EMPA, with empagliflozin. And that showed big benefits on cardiovascular death, non-fatal MI, and non-fatal stroke. And that was the measurement that was required by the regulators, what they call this composite endpoint, which are pretty hard endpoints: cardiovascular death, non-fatal MI, non-fatal stroke. And those patients, again, who were on usual care, they were on ACE inhibitors, statins, aspirin, many of them were on insulin, they got add-on SGLT2, add-on placebo. There were dramatically fewer deaths in the SGLT2 treated patients. The EMPA-REG trial was conducted only in patients who had prior myocardial infarction or prior stroke. They had established cardiovascular disease. They'd already had a previous event. In other words, they were a secondary prevention population entirely. The entire study cohort was very, very high risk by virtue of their previous disease. Then we had the Canvas program, which was a very similar design to the EMPA program. It was initiated, both of these trials were 5 or 6 years duration, but the Canvas trial recruited a different population of patients. Many of them had previous cardiovascular disease, previous MI, previous stroke, but a lot of them did not. A lot of them simply had high risk, but they had not yet suffered an MI or a previous stroke. In other words, the Canvas population was a mixture of primary and secondary prevention. Arguably a bit more realistic in terms of your average patient population. It was a global trial conducted around 30 countries, 600 different investigator sites. In order to get into the Canvas trial, you had to have an HbA1c above 7%, you had to have an EGFR above 30. Yet I've just said to you that you can't prescribe this drug unless it's an EGFR above 60. And that's why I think the licence will change in due course, because there were patients enrolled into the Canvas trial that you and I would not ordinarily treat. So they either had to have a history of a prior cardiovascular event, or they had to be over the age of 50 with at least 2 risk factors, whether that was hypertension, proteinuria, hyperlipidemia. These trials were not trials of glucose lowering. Remember, you imagine you had patients in your practice. They were undergoing routine care. They were seeing you to adjust their HbA1c, do anything you like to their diabetes care, and then they just happened to be taking canagliflozin or placebo in the background. So if all of these patients were getting perfect management, HbA1c would be identical in the 2 groups. But of course, in practice, those that were on canagliflozin might have been on 3 drugs, and those that were on placebo were only on 2 drugs. So there was a difference in HbA1c. But this trial was not about lowering HbA1c, it was about looking at clinical events, deaths, myocardial infarction, and stroke. But when you look at the data here, this shows the benefit on blood pressure. When you look at the effects on body weight, you can see the difference, and you can see the effects on HbA1c. And when you then get to the primary endpoint, again, this composite of cardiovascular death, non-fatal MI and stroke, highly significant reduction in favour of those patients treated with canagliflozin. And then one of the really surprising but dramatic benefits was this result: a big reduction in hospitalisation for heart failure. And this is one of those clinical endpoints that had been underestimated in the diabetic population. But you've got a 22% reduction in the hospitalisation because of congestive heart failure. And when you look at total mortality in the 2 groups, significant benefits in favour of canagliflozin. And much the same was demonstrated with empagliflozin, although, as I say, the empagliflozin trial was conducted in a very select, very high-risk population, whereas the Canvas population was a little bit more real-world. It included people with prior MI, but it also included people who did not have prior MI or prior stroke, who were relatively lower risk, and they still got big benefits. Also, there was evidence of renal protection. The decline in EGFR in these patients over about 7 years was less in the canagliflozin treated patients. So, as I mentioned earlier, there is an element of renal protection with these drugs, and in future we may well be using these drugs to protect the kidney in diabetic kidney disease, and we may be initiating the drug, like in the Canvas trial, with EGFRs above 30. But for here and now, the label says you can't initiate unless EGFR is above 60. So my message would be to stick with the label. Let's do the simple things well. There's loads of patients out there with high cardiovascular risk, both primary and secondary prevention, who have an EGFR above 60, whose HbA1c is suboptimal, who really ought to be prioritised to get this drug on top of usual care, whether that's insulin or on top of metformin. When you compare the EMPA-REG and the CANVAS trials on all the different outcomes, mortality, heart failure, 3-point MACE, they're virtually superimposable. But as I say, the population within CANVAS is much more representative of your average total practice population of type 2 diabetes, where you've got a mix of primary and secondary prevention. So that deals with the efficacy side of the equation. It was all good news. Those patients who got canagliflozin lived longer, they had less hospitalisation for heart failure, they had less non-fatal MI and stroke. When you look at the safety side of the equation, there was a small signal around lower limb amputation. So what was this about? The answer is we don't quite know. But there was a small increase, and it was very small, that patients in the canagliflozin arm had slightly more distal amputations. Most of those events were amputation of toes rather than limbs. And most of those patients already had a history of prior amputation or diabetic foot disease. The mechanism is not clear, but there are large observational databases now showing that the same signal will apply to all SGLT inhibitors. And indeed, there is a label warning on all of the SGLT2 inhibitors about a small increased risk of amputation. So in practice, what does that mean? I wouldn't be giving the drug to patients who've already had significant diabetic foot problems. If they've had previous amputations, or they've got previous foot ulceration, or any evidence of critical limb ischemia, I wouldn't be using any SGLT2 inhibitor. But organisations like NICE and the regulators have overwhelmingly concluded that the benefits of these drugs far outweigh the risks of amputation. But there has been a lot of noise made about the amputation signal, but in the bigger context, these patients are going to do much better with the drug. But just bear that in mind. This slide just illustrates what I mentioned about the representativeness of the CANVAS population. Whereas EMPA-REG was on the right, really was a very small chunk. If that pie is your total type 2 diabetes population, which is predominantly a mix of primary and secondary prevention, EMPA-REG probably only represents about 15% of your total population of diabetes, whereas the CANVAS trial would probably cover about half of your patient population. And the half that it wouldn't cover are those that have got reduced EGFR, because you won't be initiating it below EGFR of 60. So in future, I think we're going to hear more about the sort of renal protection side of these drugs. We're going to hear more about the heart failure benefits of these drugs, and we're going to hear more about their use in type 1 diabetes. What do the guidelines say? The ADA, the European guideline groups, have reached a sort of consensus statement that if your patient has got established cardiovascular disease, then you're going to prioritise the use of an SGLT2 inhibitor. If they've got evidence of chronic kidney disease, and particularly if they've got a history of heart failure, you're definitely going to prioritise the use of an SGLT2 inhibitor. So what that means, really, is that when you've got a patient in front of you on metformin, and you look at them and you take their history, if there's any evidence of atherosclerotic cardiovascular disease, and if there's any evidence of symptoms and signs of heart failure, you really would put them on an SGLT2 inhibitor next. Yeah?
Can you use them with loop diuretics?
You can. The labelling will simply tell you to be careful to avoid any sort of postural blood pressure drops. But you can use them on top of loop diuretics. Just be careful that you don't get an excessive blood pressure response. You use them on top of ACE inhibitors, and you can use them on top of a loop diuretic. Yes. If you read the labelling, there's often a bit of wording about not using it in patients who are elderly, but some of that is simply about risk of dropping their blood pressure. So, you know, would you use it in frail elderly people with a systolic pressure of 105? Probably not. And just be aware that it does lower blood pressure. Yeah.
So starting SGLT2s don't start if it's below 60, but let's say somebody's on it and then the EGFR is dropping, would you say, okay, I need to stop?
No, you don't. So EGFR may drop because it's a bit of a diuretic, but no. So the scenario that often happens is somebody initiates the drug and then they think, this drug works on the kidney, I better check their U's and E's in a fortnight. And they check the U's and E's in a fortnight and the EGFR's dropped to 52. And they say exactly what you say, what should I do? The answer is, don't measure the U's and E's at 2 weeks, then you won't worry about it, but don't stop the drug. The EGFR will recover.
We're told to measure it, is it 4 weeks, 6 weeks? Something? You don't measure
Not if it's not clinically indicated.
Okay.
These drugs have no nephrotoxic effect. The only issue about EGFR is efficacy. So if you're using it to lower HbA1c, you're going to get less HbA1c lowering if they're not filtering glucose. But other than a diuretic, it won't affect renal function. And indeed, before very long, you may well be initiating the drug not for its glucose lowering effect, but for its renoprotective effect through mechanisms that may have very little to do with glucose lowering. So, for example, you know, there are currently ongoing randomised placebo-controlled trials taking a population of patients with heart failure, including preserved ejection fraction, randomising these people to add on SGLT2, add on placebo on top of usual care, and they don't have diabetes. They don't have diabetes. Okay? So a lot of the benefits that we're seeing in things like the Canvas trial may actually have nothing to do with glucose lowering, because we've had lots of glucose lowering trials before, brackets DPP4 inhibitors, and we never saw any of these benefits. So why do we suddenly get the benefits? It may be independent of glucose lowering. And that's why we're now beginning to see the cardiology world all getting excited that they've got a new treatment that they can use in heart failure, whether you've got diabetes or not. So I think the whole story around these drugs is going to continue to broaden out. But for here and now, prioritise the drugs in those people who've got previous cardiovascular disease and who've got any hint or suggestion of heart failure. I think that's all I was going to say, and open it up for any questions.
The anti-reg study to show any complications of amputation, so
No.
So should we not favour ankylosing then? Ankylosing.
The FDA the problem with safety is that these signals are so small that there's a play of chance. So after the Canvas trial was published, the FDA and the European regulators went immediately to the EMPA-REG and said, I want you to interrogate your database again to look for any hint of amputation. They didn't find it. But what they did do was they commissioned a lot of what they call real-world evidence studies. So instead of having 10,000 patients in the trial, let's look at 500,000 patients who've been used in routine care. And those real-world evidence trials have shown for all of the SGLT2 inhibitors a small but real signal of amputation risk. So I think it was a little bit of chance that it happened to show up in the Canvas trial, and the warning applies to all the drugs. And so switching doesn't provide you any reassurance, really. Yeah?
Can you develop hyponatremia from SGLT2?
No, that's not
Are you taking out sodium, or is it just glucose?
You're passing out sodium and water,
Yeah.
so you wouldn't expect to get any hyponatremia. Then, no. No. Again, the people who may be susceptible to a bit of dehydration, a bit of blood pressure lowering and syncope are going to be your frail elderly patients. You know, the frail elderly patient who may then become incontinent because of glycosuria, you would probably avoid it in those sort of frailty situations. But otherwise, no. Electrolytes are not a problem. Was there another question? No? Okay.
That's it. Thank you so much.
Thank you so much for doing that. Amazing, a very practical presentation in terms of our clinical practice, and I think we all really appreciate the expertise. I know we've travelled a long way.
That's all right.
So thank you so much for that. So just going to summarise, I think we've had a 100% sign up from all the practices in City. The ones that are here today, there's one or two missing. We've given their apologies, but I will chase them up after. We just thank you so much to everybody for coming. Just a few words from our chair, just to close off the meeting and to say goodbye to our online viewers. And then we'll
I'd like to say thank you all of you to attend. I know it's been quite a long day and a long evening. I hope that all of you have actually benefited today from Dr. Kilcar, Dr. Knowledge, and the presentations. I know there's some key points that I've actually learned and hopefully will be implementing in my practice. These quality improvement programs only happen because we get the engagement from our member practices, and it's amazing to get all our practices signing up to turning up to these meetings, and we're really grateful for it. So we've got some more quality improvement programs coming up in the future. We'd like you to continue to engage with it. I'd also like to thank all our online viewers on YouTube, on the Twitter channel, as well as Twitter. So I'd like to thank you all for